Good evening, everyone. How are you all? Okay, so welcome to First Aid AMC Clinical free 2-week sessions again. So as you guys already know that we already started our first free 2-week sessions, and the first session was on 2nd of July, right? So we did our psychiatry mental status examination role play. And also like before that, that was our first trial session, which we took on 15th June on psychiatry MSc theory. So you got some idea that like how we usually take our session. We do a theory session and followed by that, we do a role play on that similar topic also. And also tomorrow you are going to have another class, which you will find quite random because that doesn't have any prior theory session, just like how I am doing. So tomorrow you are going to have a session which is a random role play session. You get a new case, you do the role play, and someone like your mentor will give you appropriate feedback and then discuss the case. So those are more exam-oriented cases and more recent cases which will help you to understand that what examiner actually wants from you and what they expect from you. And you will also get the vibe from that cases that if some new cases come in your exam, how you are going to prepare and how you are going to do that particular station, you are going to get confidence by doing this kind of random cases. But in our theory session, we are going to follow this specific cluster-wise approach, which means that we do a theory session and followed by that, usually after 2 or 3 sessions, we do a role play session on that particular topic that we are discussing. Now, tonight is cardiology session, and cardiology, we usually finish in 2 classes. So one today, and then there will be another class on 9th of July. And then 13th July, we will have our cardiology role play session. Whenever you will see that we are doing a theory class, the theory class is designed in a way so that you understand the topic in every possible detail that you really need for the exam. And we follow this cluster-wise approach, which means you just remember a particular format, and using that format, you can actually finish 5 to 6 cases without even remembering any history of those cases. Now you will find out lot of people just memorize the cases and ends up memorizing about 300, 400 cases in the at the end. And just think that if you need to remember 300 to 400 cases and you have to revise it before your exam, how you are going to do that? Which is, I don't know how people do that. And I feel like that's one of the reasons why people fail in the clinical exam in the first place. Because you don't need to do that. You have a cluster-wise approach. You follow the format. Your history is already done. You have a format for physical examination. Your physical examination is done. Only thing that you remember is the management. And sometimes management even doesn't come in the exam. So basically, you're just remembering the format. You are remembering the differential diagnosis of that cluster. And you finish the exam just remembering maybe 100 or 150 cases at the end. So see that it becomes half of your preparation and it becomes so concise with this cluster-wise approach that you will find it so helpful at the end of this course. And candidates love it, trust me. Okay, so tonight you will get a little bit idea that how we do this cluster-wise approach and if I'm saying it right or wrong. Okay, all right. Any questions? Now, I can see some of you are in the Facebook. A lot of people are in Facebook. If you guys want to come into the Zoom session, feel free to do so. If you see that you have any question and you want to stay in the Facebook live session, in that case, just write anything in the comment section. I'll be happy to answer. So what is our cluster for tonight? It's Syncope cluster from cardiology. So mainly we will focus on Syncope cluster, and maybe we will touch the palpitation cluster tonight. So what is syncope? It's a loss of consciousness in a patient, which can be due to cardiac cause, can be due to neurological cause, and sometimes maybe even psychiatric cause. So in any kind of, when we say that we are doing a cluster, the format should be in your head that we do the differential diagnosis, and this is the most important part that you need to remember. So you remember the differential diagnosis of that cluster, and then we are going to do the history. You remember the history format. Then we are going to do how to do a physical examination from examiner in case of face-to-face exam. And then we are going for management and diagnosis. So as the term face-to-face and online came up, we discussed a little bit about how the face-to-face and online exam happens in our first trial class, right? So all of you know that in face-to-face, that's actually the old method of taking the exam, and most likely that is taking over the online exam again, because you will find out that having an online exam, it is very hard to get into right now. So they have reduced the number of online examination already, and most likely that this online exam will not even there by the next year, depending on the COVID scenario, obviously. So if you are in Australia, or if you can come to Australia, then make sure you at least prepare for face-to-face exam, because that is the way to get the exam date conveniently and easily. And getting an online exam date, it is really, really hard. But if you think that you want to go for online exam, then yes, you have to just wait for it, and you have to prepare for online examination as well. We have been doing the online exam preparation for the last 1 year, because online exam was the only mode of examination during the COVID era, right? So we know fairly a lot about the online exam. So throughout the course, you will also know how to prepare for online examination and obviously face-to-face exam. Now, starting with the differential diagnosis of syncope. So what are the differential? Remember, I told you that there are CVS-related causes, there are CNS-related causes, and there are some miscellaneous or others. CVS is the important one, so any arrhythmia can give you syncope, especially if you are having a prolonged QT syndrome. Sometimes even atrial fibrillation, SVT, those can end up getting you a syncopal attack. Not very common, but it can. So any arrhythmia can cause syncope. Valvular disorder, especially aortic stenosis. Then we have HOCM, which is the hypertrophic obstructive cardiomyopathy. Myocardial infarction or ischemic heart disease, that's also important. And we have another arrhythmia, which is your prolonged QT syndrome. So these are the 5 causes that we need to remember in case of syncope differential diagnosis, which is under CVS. Then come to the CNS. So in nervous system, TIA or stroke, head injury, infection, which is meningitis, encephalitis, and epilepsy. Then we have some others, which are very important for exam also. So vasovagal syncope, postural hypotension, hypoglycemia can give you syncope. Sometimes if a patient has a long-term anemia, that can also cause syncope. Some medication, then stress or psychogenic syncope. Now, these are the differential diagnoses that you need to remember. There is no particular mnemonic to remember all of it, but you will end up remembering it when we do the cases. For exam, what are the important cases? For exam, you should remember about aortic stenosis. That is a really, really important case. Then HOCM, never I have seen. Ischemic heart disease or MI does not come under syncope, but chest pain usually like it usually comes under chest pain cluster. Prolonged QT syndrome important. None of the CNS causes comes under syncope, but you have to rule it out. Vasovagal syncope, very important for exam. Postural hypotension, very important for exam. Then sometimes like anemia, medication induced, those are not very commonly asked, but we need to rule this out, obviously. So these are usually your exam-related scenarios, which we are going to discuss today. Now, moving on to history. So history format, using the same format, you can finish those 4 or 5 cases. Let's see how we do it. Now, this is the time where you understand the difference between online and face-to-face exam. In case of face-to-face exam, there will be an examiner in the room, and then there will be a role player, and you enter into the room, you greet the examiner, and examiner introduce you with the patient or role player. You go in, you sit on the chair, or sometimes even you stand by the side of the patient bed, whatever is the scenario. Then you introduce yourself with the role player and you start your case. In face-to-face exam, if you get a case which is a very acute setting, like patient coming to you with acute abdomen, patient coming to you with an acute onset of chest pain, shortness of breath, any of the acute condition, you have to make sure that that patient is vitally stable before you proceed for any further history. So how we do that normally? So let's say this is a face-to-face exam. So, and your patient name is John. So you will say that, hi, John, this is Dr. Arshan. I'm one of the doctors here today. It is very nice to meet you. I understand from the notes that you had a loss of consciousness today. I'm very sorry to hear that, but please don't worry. Now that you are here, we will try our best to manage your symptom and find out why actually you lost your consciousness. But before I ask you any more question, I need to make sure that you are stable enough to answer my questions. Is that okay with you? Yes, doctor, that's fine. Then you turn your head towards the examiner and ask the examiner, dear examiner, is my patient vitally stable for further history? An examiner can have multiple response to that. The examiner can ask you that, what do you mean? Then you say, doctor, I would like to know the blood pressure in both standing and sitting position, pulse with rate and rhythm. Examiner will give you the blood pressure and the pulse. And you can also ask respiratory rate, oxygen saturation, and temperature. There are 5 things that we ask in the vital: blood pressure, pulse, respiratory rate, oxygen saturation, and temperature. Now, never ever ask all 5 at one go. So you just can ask 2 things at a time. So if examiner asks you that, what do you mean? Then you have to say, examiner, can you please tell me the blood pressure with a standing and sitting position and the pulse with rate and rhythm? Examiner says, blood pressure 130/80, pulse 80, regular. Examiner, can you tell me the respiratory rate, oxygen saturation, and temperature, please? Examiner says it's stable, move on. Then you say, thank you, examiner. Then you turn your head towards the patient and say, thank you so much for waiting, John. Now that I know that you're stable enough, will you please tell me a little bit more about what exactly happened today? So that is an open-ended question that you start with. Always remember, in exam, your question is always an open-ended question. Because if you don't do that, you might not even get some information which the role player intending to give it to you. That was the part of the task. But if you just ask that, can you tell me what happened? Can you tell me that what were you doing at that time? Can you tell me this is the first time or not? So you will ask those closed-ended questions, but first always is open-ended question, so that you get the scenario from the role player, which you're supposed to get. Okay, so you do that, and after that you start your closed-ended question. Okay, so that's how you will start your face-to-face exam. Is this clear for everyone? Any question? Clear, right? Good. Now let's say that how we are doing the online examination, because in online exam, the scenario is little different, because that in online exam, there will be an invigilator who will be with you during your examination on the screen. Then there will be a role player on the video, and you will be there, obviously. There will be examiner, but examiner will not show his or her video, and they will never ever answer your question. So examiner will be completely on mute throughout the online exam. So you don't ask anything from the examiner in case of online exam. Same, you don't ask anything to the invigilator related to the exam case. They are not supposed to give you anything. So in online exam, what you normally do that you start say in the same way, like, hi, this is Dr. Asha, nice to meet you. I understand from the notes that blah, blah, blah. Now, I just need to make sure that you are stable enough to answer my further questions. So what I'm going to do is to make sure that your blood pressure, pulse, your respiratory rate, and oxygen content in your blood is stable. Once it is stable, then I would like to ask you more questions about it. So let's say I'm just doing the online exam now. What I would do, say, hi, John, this is Dr. Arshan, one of the doctor here. It is very nice to meet you. I understand from the notes that you had a loss of consciousness today. I'm very sorry to hear that, but please don't worry. Now that you are here, we will take care of you, and we will try our best to manage your symptom and find out the cause. But before I ask you any more questions, I would make sure that you are vitally stable, which means I would check your blood pressure, your temperature, your pulse, your breathing rate, and your oxygen concentration in your blood. Is that all right with you? Yes, doctor. All right, so John, would you please tell me a little bit more about what exactly happened today? So what I have done, I just told the role player that I'm going to check your vitals, but I haven't done anything with the examiner in that case. And that is exactly how it sounds nice and clear. An examiner is listening to what you are doing. They are happy that you are making sure patient is vitally stable. And obviously, because if examiner can't talk, asking anything from the examiner doesn't make any sense. So that's why we are changing the way of doing these vitals from face to face. Okay, so face to face and online, the starting will be a little different, because in online you can't find anything from examiner. Now that we know about our introduction and the start of the case, let's move on. So you ask the patient that, can you tell me a little bit more what exactly happened today? So the patient will say that, doctor, I was playing tennis with my colleague, and then suddenly I felt that I'm having a lightheadedness, and then I fall on the ground and I lost consciousness. And then I can't remember anything. So you again say, I'm very sorry that happened to you. It must be very stressful to you. Now, can you tell me that, is it for the first time that happened? So see that what we have done, we always start with a presenting complaint. The presenting complaint in here is loss of consciousness. or syncope. We divide the syncope presenting complaint into three parts. One is pre-syncope, syncope, and post-syncope, which means that what happened before you lost consciousness, what happened during you lost consciousness, and what happened after you regain your consciousness. So in pre-syncope, we already asked, can you please tell me what exactly happened and what were you doing at that time? Now, if you already know that patient was doing something, then you don't need to ask this question. But if patient doesn't say that what he was doing at that time, then you ask this question that, can you tell me what exactly were you doing at that time? Is it for the first time? Did you fall suddenly, or did you feel any lightheadedness or dizziness before you fall? Now, this is a particularly important question because this is called prodromal feature. If it is a cardiogenic syncope, you will not get this kind of prodromal feature. Whereas if it is let's say it's a vasovagal syncope, they usually get those prodromal feature first. That means they know that they are going to have a fall. They get this sweating, headache, blurry vision, those kind of prodromal features will be there, and then they had a fall. So that's why we ask this question that did you fall suddenly, or did you feel any lightheadedness or dizziness before you fall? Any headache, blurring of vision, any weakness in any part of the body? This is also same kind of prodromal feature that we are asking about. Now, you can see that we are asking a little bit of CNS-related symptom here already, right? So headache, blurry vision, weakness in any part of the body, that's one of our differential diagnoses, stroke, right? So we are already asking these things along our pre-syncope question. Then come to the syncope question. Because if a patient loses their consciousness, they will not remember anything what happened during that time. So that's why we should ask that, was there any witness? If yes, then say that, if you give me the consent, I would like to talk to the witness as well to confirm what exactly happened when you lost your consciousness. Now, to confirm that patient actually lost consciousness, you can ask that, did you actually lose your consciousness? Yes. Do you know how long it was? Did you have any jerking movement of your body? That's to rule out epilepsy. Did you wet yourself or pass stool? Same. Urine or fecal incontinence? That's a feature of epilepsy. Did you bite your tongue? Epilepsy. And did you injure your head? It's a very important question. Anyone who had a fall and lost consciousness, you should always ask about head injury. Okay, and that's one of your DD also, right? See that head injury is one of your differential. So these are your syncope question that you should ask in here. So loss of consciousness, how long it was, and you rule out head injury and epilepsy. Then come to the post-syncope question. After you regained your consciousness, were you able to stand by yourself or someone helped you? Why we ask this question? Because in case of cardiogenic syncope, patient will have their syncopal attack very suddenly, and then they will regain their consciousness also suddenly. There will be no post-ictal confusion, or there will be no confusion or drowsiness after they regain their consciousness. So that's why patient will say, yes, I was able to stand by myself in cardiogenic syncope. Did you feel confused or drowsy? In cardiogenic syncope, this will not be there. Any weakness, any problem with your vision or speech? So weakness, vision problem, speech problem is to rule out TIA or a stroke. So these are your initial questions, pre-syncope, syncope, and post-syncope. After you have done that, then we move to the differential diagnosis question. So first, you start with the CVS. For CVS, only 2 or 3 questions are sufficient. So did you have any, or you can just ask, do you have any chest pain, difficulty in breathing, any racing of your heart? So that will cover every possible CVS-related differential diagnosis. Because we are asking about chest pain, difficulty breathing, that's for AMI or ischemic heart disease. Then for aortic stenosis, the only finding is chest tightness, difficulty in breathing on exertion. So we are already asking all the questions from this CBS just by these three symptoms. Any chest pain, difficulty breathing, any racing of your heart. Racing of your heart or palpitations are same, because you can't ask any medical jargon in the exam. Any medical jargon should be explained as a simple term in the exam. So that's why we are not saying, did you have a palpitation? Many patients understand palpitation, but if they don't, then racing of the heart is the easiest term that we can use for them. For CNS, any head injury, if you forgot to ask it during the syncopal question, then ask it here. Any fever, rash, neck stiffness, this is to rule out infection like meningitis, encephalitis. And that's how we cover the CNS also. Because we already asked a lot of questions about TIA stroke. We are asking head injury. We already asked about epilepsy. And now we are just asking the infection. Then there are other causes. So for hypoglycemia, only one question. By any chance that you skipped your meal today? Because a lot of patients, if they do overexertion and they skip their meal, they can end up having a hypoglycemic attack. So one question is sufficient. Did you skip your meal today? Or if you want, you can also ask that, do you have any diabetes? Because having a diabetes, and if a patient is taking insulin or any hyperglycemic agent, and they miss, let's say they took the insulin and then they missed their meal, that can end up having a hypoglycemic attack. So you can directly ask that, do you have any diabetes? But only one question is sufficient because you are asking a lot of questions and you will not have that much time. So did you skip your meal today? Then for vasovagal syncope, we don't usually have any particular question, but one question that you can ask that before you fall, were you standing for a long time? And was it a sunny, hot weather? So doing anything like any exertion, any work under a hot, sunny weather and standing for a long time, that can sometimes provoke this vasovagal syncope. So one question is fine, that were you working under a hot, sunny weather, or was it a hot, sunny weather? And you can also ask that before you fall, were you standing for a long time? For postural hypotension, do you feel dizzy or lightheadedness when you get up from the bed in the morning? So obviously in postural hypotension, what happens that when patient changes their position from sitting to standing, or even lying to sitting and then sitting to standing, they get this dizziness attack. And that's what we call as postural hypotension, because it comes with change of posture. So we just ask the patient that, do you feel dizzy or lightheaded when you get up from the bed in the morning? For anemia, do you feel tired these days? Anyone told that you look pale these days? Then you have stress. So you can just give some confidentiality, like, John, I want you to know that whatever we are going to discuss here today, it is confidential. So I'm going to ask you about your family life. So please be frank with me if anything going on. So who do you live with at home? Is there any stress at your home? Do you do any work? Is there any stress at your work? Because stress can induce a lot of psychiatric problem, which can mimic some organic disease. Like patient with stress or psychogenic problem can end up coming to you as a syncope. So always try to rule that out if you have time. And then past medical history. So are you generally healthy? Do you have any history of diabetes, high blood pressure, or any other heart condition? Any family history of heart condition? Any family history of sudden death? Ask about SADMA. So SADMA, normally we just ask about smoking, alcohol, and medication. So do you smoke or drink alcohol? Do you take any regular medication? And remember one thing, in case of syncope, family history of sudden cardiac death is very important, because if there is a history such as like this, what are your main differential diagnoses at that time? So if you get a patient who has a history of sudden cardiac death in the family, and now the patient having a syncopal attack, what is your two most important differential? Guys, yes, one is HOCM and another is prolonged QT syndrome. So these are the two conditions which can give you a sudden cardiac death, and that can run in the families. Aortic stenosis doesn't run in the family, but HOCM and prolonged QT syndrome, those sometimes run in the families. Okay. So this is the format. And then your history is done. You say that, thank you so much for all the information, John. Now I'm going to my examiner and then come back to you in a minute. Or then you can say, thank you so much for all the information, John. Please excuse me for a moment. I'm going to talk to my examiner and then I'll come back to you. Okay. So always say something like that at the end. A lot of candidates, they just finish the history without saying anything. They just go to the examiner, and that's very mean to those role players. And you can just fail globally, and you have done everything right, but still you are failing globally with your approach. So approach is always important aspect of the exam. When you get your exam sheet, you will always find that every task has the first thing that you are marked with is your approach. So approach to the patient, you always get a specific mark from them. And that has a great value to that station, because if every time you finish your station, the examiner asks from the role player, did you like this candidate? Did you like this candidate approach? If that role player say no, you fail the case. So make sure you take it seriously, okay? So now that you understand the format of the exam, at least the history, let me give you the shortcut. The shortcut is you remember the differential diagnosis when you are waiting outside in the 2 minute. In 2 minute time, you first remember all the differential diagnosis. If you can, then just think that what is the history format. If you can think up to this, that case becomes much easier. So for syncope, first of all, we make sure patient is vitally stable and then go to the presenting complaint, pre-syncope, syncope, syncopal question. After that, we go to the DD. So all the CVS, CNS, other differential diagnoses we'll be asking. And then we always finish with past medical history, SADMA, and family history. This is how we finish all the history. Okay, any question with the history, guys? All good, I guess. So the next question is a physical examination from examiner. Now, again, there is some difference between online and face-to-face exam in this part. Someone asked that, do we need to ask about previous surgical history? I don't know what your name is, doctor. Your name is showing as admin, but that's fine. So previous surgical history, sometimes we ask it, but for this case, it isn't. Now, even if you ask, like any previous medical or surgical history, that's not a problem at all, but not much important for this cluster. All right, Priyanka. Okay. So physical examination from examiner, as we are talking about it, that online and face-to-face is a little different, because in face-to-face, your task is always like this: ask physical examination finding from examiner. Now, this means that you don't need to do physical examination on the patient, but in here, You ask the finding from examiner and examiner give you the finding. But in case of online examination, the tasks are various kind of tasks. One task can be like explain to the patient what physical examination you are going to do, and then a physical examination card will be given on your screen. So that is one of the common physical examination tasks in online examination. Again, this is not the physical examination. This is a part of your like a history, physical examination, diagnosis, DD, those kind of thing. Not solely a physical examination station. So in that case, if they say that discuss with your patient what physical examination you are going to do, then you will just say that what you are going to do. We will discuss that. But after you have done that, then examiner will give you the finding on the screen. You see the finding on the screen. You don't need to say it loud. You just read it within a minute or so, and then you go to your next task. Okay, so that's online examination. So the difference is that in online examination, most likely you are going to get a physical examination card on the screen, and you just read it by yourself and go to your next task. In case of face-to-face exam, you have to ask the physical examination finding from examiner. So how we basically do that? So remember that we finished our history and then we go back to our examiner and say, this is face-to-face. So dear examiner, I would like to do physical examination on my patient, John. I would like to know about the general appearance. Is my patient comfortable or in distress? Then examiner says, patient is comfortable. I would like to know if there is any pallor icterus. No. Any clubbing, dehydration, or any edema. Examiner say negative. So that comes your pickled. Throughout the exam, your preparation, pickled will be there. Now, pickled is a mnemonic for our basic general examination. So P for pallor, I for icterus or jaundice, C for cyanosis, then K for clubbing, although it should be C, but we are remembering it as a clubbing. Lymph node, E for edema, and D for dehydration. Now, do we ask all of it? No, we just ask the relevant one. Obviously, for a syncope, icterus is not very important. Then the lymph node is not important. So we don't ask this. So you can just ask that, dear examiner, I would like to know if there is any pallor, cyanosis, no, any clubbing, edema, or dehydration. Examiner says negative. I would like to know the vitals, please. So if you did not get your vitals initially, then now you should get it all. So in case of syncope or any cardiac vital, you ask that, I would like to know the blood pressure in sitting and standing position and pulse with rate and rhythm. Examiner will give you the answer. And then I would like to know the respiratory rate, temperature, and oxygen saturation, please. I would like to start with neck, looking for any raised JVP or carotid bruit. Examiner says negative. Then I would like to do a focused systemic examination from head to toe, but first focusing on cardiovascular system. On inspection, is there any visible cardiac impulse? Examiner says no. On palpation, is the apex beat normal in position? No. Any palpable thrill? No. Any parasternal heave or palpable P2? On auscultation, apart from S1 and S2, is there any other added sound like murmur? Now, when you have to remember that you will have a particular system which is important for that case. For a syncope cluster, cardiovascular system is your main system. So you always start with that system first. A lot of candidates, they do this kind of thing, like they start with CNS, they start with abdomen, respiratory, and then at the end ask CBS. But you will always have to ask the most important system first. That is your format that you remember. Okay, so because CVS is your main system, you are asking it in detail. But the others, like CNS and other system, you can just ask it very shortly. So once CVS is done, then you say that I would also like to do the full central nervous system examination, both upper limb and lower limb, including the cranial nerve. I would like to finish with all other systemic examination, including abdominal exam, respiratory system examination. Examiner will say those are normal. Is there any office test available, examiner, like urine dipstick, blood sugar level, and ECG? Now, when we come to the office test means some test which you can do as a bedside test. And in the exam, you can only ask 4 or 5 office tests. What are those? One is the urine dipstick and BSL. That's usually we ask for every cases. So urine dipstick, blood sugar. ECG we can do as a bedside, but we only ask it in the cardiac system, not anywhere else. Then sometimes, if it is a respiratory case, you can ask the spirometry finding. That's an office test. You can ask the urine pregnancy test in case of obstetric cases. So these are basically your office test. Sometimes ABG, VVG, if it is important for the exam, then you can ask it. All right. So office test is not X-ray. So you don't ask about X-ray chest, ultrasonogram of the abdomen in your office test, because those are your investigations and you need to wait for this test to come back. Okay, and that's a part of your management as well. But this office test, sometimes you can just do it on the bedside rather than waiting for a long time. Okay. So let me just do a physical examination from examiner and just remember how I am doing it. And for the rest of the course, please remember it. Okay. Don't ask me in the middle of the course, doctor, how to do the physical examination from examiner. All right. So dear examiner, I would like to do the physical examination on my patient John, starting with the general appearance, please. Is my patient ill or distressed? I would like to know is there any pallor, cyanosis? Is there any clubbing, edema, or dehydration? I would like to know the vitals, please. Blood pressure with sitting and standing position, pulse rate, pulse with rate and rhythm. I would like to know the respiratory rate, oxygen saturation, and temperature, please. I would start with the neck examination, looking for any rate JVP or carotid bruit. Then I would do the focused systemic examination from head to toe, but mainly focusing on cardiovascular system first. On inspection, is there any visible cardiac impulse? On palpation, is the apex beat normal in position? Any palpable thrill? Any parasternal heave or palpable P2? On auscultation, apart from S1, S2, is there any added sound like murmur? I would like to do the full central nervous system examination, both upper limb, lower limb, including the cranial nerve. And then I would finish with full systemic examination, which is the abdominal exam and respiratory system examination, please. Now, do we need to ask in detail about those? No, because you don't have that much time in the exam. Is there any office test available, like urine dipstick, blood sugar level, and ECG? All right, so then examiner will give you all the information and you thank the examiner, come back to the patient. All right, so that's your format for the history and physical examination. For online examination, because they usually give you the physical examination card, you don't need to do anything. You just read the card, get your finding, and move to the next task. Any question of this physical examination and the history format? Because if you remember this format, you will not need the history and physical examination for any of the cases that we are going to do next. So I've seen some of the questions. So doctor, will we be able to make a note of the finding during online examination? Now, if you want to do it, yes, that's fine. There is no problem with that. But I would not focus on that, because you are just reading the finding, and just after that, you have to give your diagnosis. So why to write these things? You're just wasting your time when you are writing. So try to make it as a habit that don't write too much thing. I know that writing things make it easy, but it also wastes your time, and you don't have enough time in the exam. And Dr. Anika, same answer. Yes, you can write notes during the examination. And yes, Dr. Priyanka, yes, ABG usually you will not need to do in your exam because you don't get that much sick patient. You can make notes while you are taking history. Yes, you can do it. That is permitted. Both face-to-face and online examination, you can take notes during your history, during your physical exam. But try not to do that because it takes a lot of time. All good. Now, we will start with our cases, which is the aortic stenosis. We'll take a break later on. Let's move on. So, aortic stenosis is our first case from the syncope cluster. So, you have got a patient who is a 52-year-old male consulting to you about a recent loss of consciousness, and you are in a GP setting. Now, this is how a question appears in your exam. You always look for few things in a question. First, you look at that what's the setting? Is it a GP setting or is it a hospital setting? Because your management differs from this setting wise. So you always look at that. You look at what is the age of the patient. Is it a male or female? And then you look at what is the main presenting complaint. If there is any other information, then you just give a read about it, like any past history, anything that's important for that case. But this is the main thing, the age of the patient, what is the setting, and what is the main symptom. Because you remember the differential diagnosis based on this initial symptom the patient is having. Your task is to take a focused history from the patient, physical examination from examiner, ask for necessary investigation from examiner, and discuss the diagnosis and management with the patient. So everything will be written in detail, that what is the, like where you take history and what is the examiner job. So everything will be written in detail. So usually you take history from the patient, physical examination from examiner. If investigation is not a task most of the time, but if it is a task, most of the time you have to ask investigation from examiner and then diagnosis and management with the patient. So what are the positive points in this case? The positive points were that patient was playing tennis and it started to black out. Okay. So that was the presentation, that patient was playing tennis with a colleague and suddenly he started to black out, and then he had a fall and lost consciousness. For the last 2 months, he also had this chest tightness or pain and exertional dyspnea. That means whenever he is doing some exercise exertion, he's getting chest tightness and dyspnea. Now, this is a classic triad of aortic stenosis. So aortic stenosis triad is syncope plus shortness of breath on exertion plus chest pain or chest tightness. So there's the classic triad that you have got in here. And in the physical examination, you might find that patient apical impulse has been displaced, but the most important finding is the murmur that gives you a diagnosis. So you get a ejection systolic murmur, in the aortic area, which radiate to the neck or carotid. Okay, so that will be your finding in your physical examination. Now, saying so, one of the other important thing to remember that, let's say when you came to the physical examination from examiner, in auscultation, you ask that apart from S1, S2, is there any added sound like any murmur? Examiner say, yes, there is a murmur. So will you just move on, or will you ask more detail? You ask more detail from examiner. So you say that, dear examiner, I would like to know if the murmur is systolic or diastolic murmur, and I would like to know the type, intensity, and site of the murmur. So type of the murmur, you can get ejection systolic murmur. You want to know the site. So examiners say it's in the aortic area. And also you need to know if there is any radiation. So murmur has a lot of questions, but we don't need to ask all of it. We need to know that what is the type of murmur? Is it systolic or diastolic? If it is systolic, then is it a pansystolic murmur or ejection systolic murmur? We need to know where exactly is the murmur, like aortic, mitral, where it is. And we need to know that if it is radiating to anywhere. Aortic murmur, which radiate to the neck, is the aortic stenosis. There is another murmur which also radiate, and there is a hollow systolic murmur. That is your mitral regurgitation that radiates to the axilla. So these are the two murmur which usually radiates. So you can easily remember it, that ejection systolic murmur in the aortic area radiating to the neck, that is what we call as aortic stenosis. So once we know, we say that we don't need to do the history and physical examination for this case because we already have done that. So you explain that most likely from history and physical examination, you have got a condition called aortic stenosis. Do you know what it is? No, doctor. Well, don't worry. Let me draw a picture for your better understanding. Now, again, there is a little difference between online and face-to-face. In face-to-face, you always draw a picture. That's the best way to explain things to a patient. In online examination, you can't do that, so don't bother with drawing picture. Just explain it like as much as you can. So in face-to-face, always when you give diagnosis to a patient, don't say that you are having a condition called aortic stenosis, because you are a junior doctor. When you are appearing AMC, always act like you are a junior doctor. Don't think that you are giving this exam as a specialist. They don't want you to be acting as a specialist in AMC. That is one of the worst case scenario which commonly happens because many of you are already a specialist in your country and you are dealing with these kind of things, right? So if you feel like that, no, because I know all of it and I am one of the specialists working in my country, I am a cardiologist in my country, so I will just deal with this by myself. I will not involve anyone. You immediately fail this case because most of you will end up getting a job in Australia, either as a resident medical officer, or if you have a long-term experience, then highest as a registrar. But I always say, if you are coming from another country, at least start as a RMO, even as a senior RMO, that's fine, because you need to understand the system first. You might know everything, but still the system is complicated. So what you need to do, you always act as a junior doctor in the exam. That's the main thing you have in your head. Throughout the exam, you feel like what you used to do when you were a junior doctor, okay? Like an intern, or maybe just a little bit of HMO, like a house medical officer, something like that, okay? So you will say that most likely you are having a condition called aortic stenosis. Let me draw a picture for your better understanding. So this is your heart, and your heart has got 4 chambers. Always remember that when you are explaining things, you can't use any medical jargon. Now, obviously, diagnosis is a medical jargon. when you use a medical jargon, you have to explain that properly. So your heart has 4 chambers, and you can't say that it is like first one is called atrium, second one is called ventricle. You don't use those terms. You will just make things a lot complicated for a patient. So you say that this is your heart. Your heart has 4 chambers. Each of these chambers has a door-like structure known as valve. See that we talked about valve, which is a medical jargon, but we already explained it like a door-like structure. That is the way to use a medical jargon in the exam. You can use it, but you have to explain it. In your case, the valve that controls the flow of blood from heart to aorta, known as aortic valve, is narrowed. So when you are explaining, you draw the picture. So this is your heart. Your heart has 4 chambers. Each of these chambers has a door-like structure called valve. In your case, the valve that controls the flow of blood from your heart to the aorta, known as aortic valve, is narrowed. And this aorta that you can see, it is the biggest blood pipe that supplies your whole body. Now, because this valve is narrowed, blood cannot go to your body effectively, especially if the blood supply to the brain is reduced. It can end up causing a loss of consciousness, just like that you had it today. And when you exercise, the demand of oxygen from the heart gets increased, but as the valve is already narrowed, it cannot supply enough blood and oxygen, and that causes the chest pain and shortness of breath during your exercise. Now, this explanation is very important because we always try to correlate our patient's symptom with the patient's condition. What does it mean? It means that we know that aortic stenosis gives chest pain, it gives shortness of breath. Our patient also having the similar symptom. When you can correlate this symptom with the condition, that is the only time patient will understand that, yes, this is the reason why I am getting shortness of breath whenever I play tennis with my friend. And then they will feel relief that, yes, at least it is a medical condition and my doctor already knows about it. So this is not just for your exam. This is for your whole life. When you practice in Australia, anywhere, not just Australia, anywhere, you remember this thing that always try to say that why you are having this symptom, because your condition is making that symptom that you are having. So everything is explained. So why this patient got syncopal attack? Because this valve is narrowed, blood supply to the brain is reduced, and that's the reason patient has got the loss of consciousness. And whenever patient is doing any exercise, the demand of oxygen gets increased, but this valve is already narrowed. So it cannot supply enough blood and oxygen, and that causes the chest pain and difficulty breathing patient has during exercise. Now, most of the time, they can just say that give your diagnosis and differential diagnosis. That might be your only task. If differential diagnosis is a task, then you have to add few things here. You don't need to do the management if that is not a part of your task. So you say that it could be due to other causes as well. Then you remember all the differential diagnoses that you have done. So it could be due to other causes as well, like it could be related to heart rhythm disturbance, but we have checked your ECG, it did not show anything like that, and you don't have any racing of your heart as well. It could be ischemic heart disease, but you are not getting any chest pain frequently, and especially your chest pain does not sound like a cardiac or a ischemic chest pain. Also, we have done your ECG, it did not show anything like that. It could be some brain-related condition like a stroke, but you don't have any weakness, blurring of vision, problem with your speech. Could be head injury, but it is not in your case. It could be epilepsy, but you did not bite your tongue, did not have a jerking movement in your body during your loss of consciousness. It could be some other causes like vasovagal syncope, but you had a fall which happened suddenly, but in vasovagal, it happens gradually. And you know that you are having this fall. It could be postural hypotension, but you don't feel dizzy when you change your position. Could be lack of blood sugar, but you did not skip your meal today. It could be related with some stress, but you are not having any stress at the moment. So these are very unlikely in your case. So that is called differential diagnosis. And this is exactly how all of you should say the differential diagnosis in your exam. There is no particular way to do that. That's why I haven't written it in the note, because you just give this differential diagnosis, how you actually ruled it out in this history. Because you asked everything, right? You know that why your diagnosis is aortic stenosis and why not the others. So you just give some of the differential diagnosis and say that why you are not feeling that this is the diagnosis. Okay, does this make sense? So now there is no hard and fast rule that you have to say 10 DD. At least the most important DD, if you can touch, that's fine. I would say at least 4 to 5 important DD is all that you need. So if management is a task, then you have to go more. So you have to say that if it is an emergency department or hospital setting, then you can say that, or let's say it's a GP setting, right? So say that in terms of management, I would like to refer you to the hospital to confirm my diagnosis and to rule out other diagnoses. They will do some investigation such as full blood count, your kidney function, inflammatory marker. They might also do another ECG, a chest X-ray, and an echocardiogram, which will confirm if you have got any narrowing in your aortic valve. And the echocardiogram is a kind of just an ultrasound scan and looks how is your heart doing, and also it can show the valvular action or function. You will be also seen by a heart specialist, and further treatment will depend excuse me, guys. Sorry. So further treatment will depend on the degree of narrowing of the blood vessel and severity of your condition. So the further treatment actually depend on how severe is the stenosis of the aortic valve. Depending on, it can be conservative or surgical. Most of the time, aortic stenosis, if it is symptomatic, patient will have a surgical approach if patient does not have any other surgical comorbidities. Once you are stable and discharged from the hospital, I will follow you up on a regular basis. Please try to avoid any strenuous activities and adopt a healthy lifestyle modification. Okay? And at the end, just say that, do you have any question? Now, as you can see, this is not just like a full management that you are talking about. And in exam, because you are a junior doctor, you just need to touch the management part. You never go in detail of management because that will be done by the cardiologist. You just give the patient an idea that what it can be. So mainly your job as a junior doctor or as a GP is to refer this patient to the hospital. They would do this investigation, especially an echocardiogram, which can confirm the diagnosis and also confirm how severe it is. You will be seen by a cardiologist, and then the management will depend on the echocardiogram report. Lastly, you just finish that once you're stable and discharged from hospital, please come back for a review so that we can talk about it, and also I can follow you up on a regular basis and give some advice like please avoid any strenuous activities, adopt healthy lifestyle modifications. Okay, so that's your aortic stenosis management or the explanation that you really need to do. As I said, most of the time it comes as a diagnosis and DD, so usually you don't need to bother with the management too much. Cardiac marker, if a patient has got chest pain, then cardiac marker will be important. Otherwise, it's not important for now. All good, guys? So let's take a 10-minute break now. Then after that, we will do more cases. Our next case is the prolonged QT syndrome. Are you guys enjoying the session so far? I know that this is a lot to take, but trust me that the things that you are learning today, you will use that for the rest of your preparation. So these are few classes which are like pearls. So these are the basic, and depending on this basic, you improve yourself. So these classes will be needed for your whole AMC clinical preparation. Whatever you do, like if you don't enroll the course, that doesn't matter, but you are learning something which you will need, and you are actually in the right direction now. You will see that how everything starts to make sense after few classes. Okay, all good. So hopefully you are understanding. And yes, we don't usually take a ECG class as part of the course, but all of you will get a ECG class, which we normally take in our MCQ session. But as part of the clinical preparation, the amount of ECG that you need to know, that will be discussed. But not the whole ECG, which is not needed actually for your exam. Okay, because you will need to know the atrial fibrillation, supraventricular tachycardia. You will need to know the actual flutter. You will need to know all the MI pericarditis ECG. Those ECG we will discuss, and that's actually our next class. Okay. All right, let's take a 10-minute break and then we will start again. All right, everyone. So let's start again. So the next one is prolonged QT syndrome. A 19-year-old girl comes to the emergency department because she fell unconscious 2 days ago while she was climbing up a mountain. Task is same. Now, when a 19-year-old had a syncopal attack, there is a lot of things that can give syncope in a 19-year-old. Obviously, all the differential diagnoses that we already had, that will be there, but not too much about stroke or TIA because that's not very common in a 19-year-old. But all other DDs are important. Along with that, for a 19-year-old, you have to make sure you rule out reproductive age-related complication, especially pregnancy or ectopic pregnancy as well. So don't forget to ask about their menstruation history. That's important. Like you just need to make sure that any reproductive age female, you always ask, ask about their menstruation. So that will be added in the history. Apart from that, others are all good. So the history is patient was climbing up a mountain and then she had this loss of consciousness, which was sudden. This is the third time that it happened. And each time she was doing different things. Apart from this syncope, there was no shortness of breath, no chest pain, no palpitation. History of unknown heart disease in a maternal uncle. So that's your main clue that what actually they are trying to say. In the physical examination, there was no finding. Everything was normal, not even a murmur. Now, if there was a murmur of hook'em, would be one of your differential diagnoses at that time. Because having an unknown sudden cardiac death or unknown heart disease in a family, we think about either it is a prolonged QT syndrome or hook'em. But if it is a hook'em, then there will be a murmur. But obviously in a prolonged QT syndrome, there will be no murmur. That's how you can easily differentiate between these two. One of the tasks would be investigation from examiner. The investigation that you will be asking is the ECG. And then they will give you a ECG which will show prolonged QT. Now, to understand it, let us just start a little bit about this ECG. We will not go in detail tonight. So a normal ECG has this P wave followed by QRS complex. And then you have this ST wave or ST segment, then followed by a T wave. So we have a P, then we have QRS and T wave, right? So that's your normal ECG. The QT interval starts from the start of the Q wave and end of the T wave. So this is the end of the T wave. This is the start of the Q wave. That's your QT interval. In a normal patient, in men, we call it prolonged QT if the QT interval is more than 440 millisecond, and in women more than 460 millisecond. Now, obviously, you don't know how to do that or how to measure it in an ECG. The easiest way to remember that in a normal patient, the QT interval is 8 to 11 small square. How much? 8 to 11. So 8 to 11 small square, that's the normal QT interval. If it is more than 11, that's the time you call it as a prolonged QT syndrome. So when they give you the ECG, the task would be to interpret this ECG to the examiner. Tonight, we are not discussing how to interpret ECG to an examiner. That's our next class job. But let us just see that when you get an ECG in the exam, what actually you look at, because you don't have that much time that you will just waste 1 or 2 minutes just by looking at the ECG. So you have to be very quick and smart, because you already will have some idea that what is this case about. Because if it is a MI or pericarditis, patient would have chest pain. Then obviously you would look at the chest leads, which is your V1, V2, V3, V4, V5, V6. Now, this patient does not have any chest pain, so we don't need to look at this at first, right? Any arrhythmia, we mainly look at the long leads. So long lead is the last lead that is given like this. Most of the time, lead 2 is the long lead. So you look at the long lead at that time. In the long lead, you will try to first find out that what is the rate and rhythm. So obviously, that this patient does not have palpitation, so rate doesn't matter too much. Rhythm is that what is the distance between two RR interval. So you can see that this is 1 large square, this is 2 large square, 3 large square, 4 large square. And so that's 4 large square in 1 RR interval. Then there is 1, 2, 3, 4. So same RR interval. That means the rhythm is regular in this patient. So most likely it is not something to do with atrial fibrillation or SVT or AF or atrial flutter. The next thing that you look that the next thing you look at that, well, if there is no problem with the rate and rhythm, then let's just give a look at P wave, QRS, ST wave. So P wave looks normal, QRS looks normal, T wave looks normal. None of them having any visual deformity. Like P wave is not inverted, T wave is not inverted, and QRS complex is not too wide or too narrowed. So nothing of that sort. If you don't get anything positive in the ECG, immediately look at the QT interval. So then you find out, so this is the Q wave, and that's our T in like end of T. So in one large square, there are 5 small square, right? So in here, there are 5 small square. In here, there are another 5. In here, another 5. So this patient already has got 15 or 16 small square. And that means that this is a patient who has got prolonged QT syndrome. Okay? And I would like you guys to be very smart. If you get a 19-year-old who had a family history of heart condition and now having frequent syncopal attack, I would look at the QT syndrome because that's my most likely diagnosis. Okay? So be very, very clear in your head that what you're looking for. Then it doesn't take too much time. All right. Is this understandable, guys? Like, did you guys understand how I found prolonged QT syndrome? Yeah, good. Great. So now you explain that most likely from your history, physical examination, and ECG, you have got a condition called prolonged QT syndrome. Do you know what it is? No, doctor. Well, don't worry. Let me explain in detail. So remember the time when the nurse has put some leads on your chest? And the test that we have done at that time is called electrocardiogram of your heart, which is supposed to record any electrical activity in your heart. Now, let me draw a picture so that you understand what I am talking about. So this is your heart, and your heart has got some kind of electric activity to pump the blood throughout your body. And this ECG has different part which represents different component of this activity. In your case, the part that we call QT interval is markedly prolonged, and that is why the name prolonged QT syndrome. This condition is commonly associated with abnormal heart rhythm, resulting in impaired pumping of blood. And especially if there is impaired pumping of blood, your brain doesn't get enough blood supply, and that's why you get these frequent collapse. Do you understand what I'm talking about? Yes, doctor. Always involve your patient. Ask that, are you understanding me? Is there any questions that you are having? So that's your explanation. Now, a lot of candidates from a lot of different courses, I don't know why, but they discuss the ECG in detail to a patient. And this is actually not appropriate because even a lot of doctors don't understand the ECG very well. And that's fine because this is actually hard. So how a patient who did not even have a look at this ECG anytime in their life, do they actually care about the ECG component? Do they want to know what is P wave, QRS complex, what is T wave? No, you don't go in that. You just explain superficially that this ECG is your electrical activity of the heart. It has different components and it has different parts. One of the component called QT interval is prolonged. And this prolonged QT is associated with abnormal heart rhythm, resulting in impaired pumping of your heart. Because there is impaired pumping of blood, sometimes your brain doesn't get enough blood supply, and that's the reason you are getting this frequent collapse. Now patient understand, yes, this is the reason why I am getting this collapse. Otherwise, patient would be terrified about it, right? So you have to make sure that they understand that what is their condition and why they're getting this symptom. Correlation of the condition and symptom, it is one of the vital part of explanation. Now, sometimes your task would be just diagnosis and differential diagnosis. So then you just give the differential as we have done previously. If management is a task, which I have never seen, but just remember it. So say that, please don't worry, this is not a very uncommon condition. Sometimes this runs in the family. Sometimes it can be due to some medication, dehydration, salt and water imbalance. Unfortunately, it can sometimes lead to serious consequences. That's why I need to admit you to the hospital and call the cardiologist or heart specialist to review you. Please don't worry, you are in a safe hand and we will do our best to manage your condition. Time to time, reassure the patient, give some hope, and that matters a lot. A specialist might do fewer investigations like full blood examination, your kidney function, liver function, your blood sugar level, and the echocardiogram. The echocardiogram is an ultrasound scan that looks for your heart pumping action, and also it can look for your any other valvular issues as well. Once we do the echocardiogram, if there is no other issues, and if we can confirm that it is a prolonged QT syndrome, then he might start you on a medication known as beta blocker. If that fails, he might put you on a cardiac pacing as well. Please don't get stressed about all of it at the moment because the cardiologist will do the investigation and discuss all with you in detail. Also, if all the investigations come normal and we can't find any cause, then we call it congenital prolonged QT syndrome, which runs in families. At that time, we might need to arrange family screening by doing an ECG in your family members. Once you are discharged from the hospital, I will write a letter to your GP and he will follow you up regularly. Please don't worry, you are in safe hand and we will do everything possible in our hand to make sure you feel comfortable. Do you have any questions? Do you want me to call any of your friends or family members? Always say something like that at the end. Give some hope, give some reassurance, and then finish the case. Okay? So that's all about this case. Now remember one thing, we never go in detail of management, we just touch it. So only management that you need to talk about is doing this investigation, involving the cardiologist, and talk about this medication and cardiac pacing. That's all, nothing else. Next is postural hypotension. Now, this is a little different. This falls under this cluster. There are two kinds of cases. One that a middle-aged woman comes with dizziness for the last several days. Now, dizziness, lightheadedness, syncope, all similar cluster. Okay, don't get twisted about these terms. They are more or less same, and differentials are more or less same. The other one is a 65-year-old man comes to see you because he had a fall yesterday. Okay, so also like having a fall comes under the syncope cluster. Your tasks are same. The positive points in this case was patient feels dizzy when standing from a sitting or lying position. So remember, we have a differential diagnosis of postural hypotension in the syncope cluster. So when you come across all the DD, you will find out this patient has got a dizzy episode when standing from a sitting or lying position. Then you immediately think that this is a postural hypotension case. Once you know that this might be a postural hypotension case, you try to find out why this patient has got postural hypotension. It's not just it comes without any reason. So always in exam, in your history, if you get a positive finding, then you go into the detail. Otherwise, you just ask one question, then you go to the next differential. Now that we know that this patient has got postural hypotension, our main thing is to find out the cause of it. The causes of postural hypertension can be manifold, but one of the common one which come in exam is the medication-induced postural hypotension, which is the polypharmacy. So patient might have started a new blood pressure medication, or maybe he has started with a diuretics. Something will always be there which has caused this new onset postural hypotension. So find out the medication and specifically ask that, is there any medication which you have recently increased the dose, or did your doctor started a new medication? So that's when you will find out that maybe patient has got a new blood pressure medication, and that's the cause of it. Apart from that, what else can it be? Postural hypertension can be due to dehydration. So it could be excessive vomiting, excessive diarrhea. So ask about diarrhea, ask about vomiting, ask about any burn recently, ask about any heavy sweating recently, ask about any recent infection. Infection or sepsis itself can give postural hypotension. Okay, so those are the important things you would like to find out, that why this patient has got a postural hypotension. Also, if a patient is getting any blood going out with their stool, like either it's a melena or a parectal bleeding, that can also cause this kind of postural hypotension. So bowel habit is important in this case. So in the history, you have found that patient feels dizzy when standing from a sitting position. Patient is also diabetic for many years, but it is well controlled. When it is well-controlled diabetic, you don't think about diabetic-induced autonomic neuropathy, because one of the complications of diabetes is autonomic neuropathy, and that can also present as postural hypotension. Okay, so that's why sometimes if you get an uncontrolled diabetic patient, then obviously you need to ask about some other autonomic neuropathy questions, like ask about, like, do you get early satiety? Do you get any changes in your bowel habit? Do you get nausea? Do you get heartburn? Okay. Sometimes they also get sexual disturbance. They also get pins and needle sensations, numbness. Those kind of autonomic neuropathy features we can also ask to the patient. Especially the features with autonomic neuropathy, they come with early gastric emptying, so early satiety or feeling hungry even after eating, then feeling very nauseous, having a lot of burping, reflux-related problem, and they also get some bowel issue, they get sexual disturbance like erectile dysfunction. So those kind of symptomatic questions we will ask at that time, but if it is a well-controlled diabetic patient, we will not go into that. Okay. So in here, there was a history of heartburn and loose stool, but no blood in the stool. That was your only history. So patient is actually having postural hypotension because of polypharmacy. And most likely these diuretics and ACE inhibitor is causing it. Physical examination, what is the most important physical exam here? Blood pressure. So when you ask the examiner, I would like to know the blood pressure, examiner will say 130/80. But if you don't ask the examiner that, can you please tell me the blood pressure in sitting and standing position, then only you will get it. So then examiner will say sitting is 130/80, standing is 100/70. So if you get more than 20 millimeter change in systolic blood pressure or more than 10 in diastolic blood pressure during changing the position, that's your postural hypotension. And that gives you a diagnosis, right? So it's very easy to forget this thing in exam. But if you don't ask it definitively, examiner will not give it to you. So that's one thing to remember. You only get finding if you ask it. You don't get finding if you don't ask it. So examiner will not give you anything just by liking you. You need to ask it. So that's your physical examination from examiner, and others will be all normal. There is another history of postural hypotension where patient was sitting in a chair. While standing from sitting position, patient collapsed. So that's one other case that can come up in the exam. Another one, that patient was taking a psychiatric medication called risperidone, so most likely for schizophrenia, and now coming with dizziness. Risperidone, one of the side effects of it is postural hypotension, and that's most likely causing this dizzy episode. So a lot of things can come. You just need to find out the history and then manage accordingly. So medication-induced postural hypotension is the most common cause. So in the first case, where the patient actually is a diabetic, how would you explain to the patient? So say that most likely from history and physical examination, you have got a condition called postural hypotension. Do you know what it is? No, doctor. Well, this is a condition in which there is sudden drop of blood pressure when you change your position from lying or sitting to a standing position. So that's the reason why when you get up from your bed in the morning, you feel very dizzy because you are changing your position. It could be due to many reasons like severe vomiting, diarrhea, high fever, strenuous exercise, but in your case, most likely it is due to the multiple medications you have been taking. Now in here, it depends, like if you get a finding that recently one of the medication has been increased or one new medication has been added, that most likely the cause of your recent onset of dizzy episodes. Also, as you are diabetic, it could be due to another condition called diabetic autoneuropathy, which manifests as heartburn, bloating, diarrhea or constipation, difficulty in passing urine, and also sometimes sexual dysfunction. But as your blood sugar is well controlled, it is very less likely. This type of dizziness or fall could be due to other reasons like heart rhythm disturbances, but you don't have any palpitations or racing of your heart. It could be due to some structural heart disease, but you don't have any chest pain, any difficulty in breathing, and also we would do further investigation to rule out any other heart condition. Could be ischemic heart disease, again, you don't have any chest pain, so it's unlikely. Could be a stroke, but you don't have weakness, any problem with your vision or speech. Could be head injury, could be salt and water imbalance, and sometimes it could be even a vasovagal syncope, but you are not working under a hot sunny weather, so it is also very unlikely in your case. So most likely, I am thinking that the reason of your feeling dizzy is because of the new medication that you have started with. But to rule out all other differential diagnoses, I would like to do further investigation. The further investigations are full blood examination, inflammatory marker, kidney function test, blood sugar, liver function, and also a ECG. Now, if this is the medication-induced one, then you can say, I would also consult with your doctor who started this medication so that these medications can be reviewed either to change it or to reduce the dose. Okay, so now there are some other management that we will discuss. In postural hypotension, the exam usually asks you to give diagnosis with reason because they want you to find out why this patient has got postural hypotension. So management is usually not a task. But if management is a task, then for postural hypotension, depending on what is the reason, you treat accordingly. Like in this case, medication is the problem. So you consult with the doctor who has started this medication. You can either change it or reduce the dose. The other one is the risperidone-induced postural hypotension. So same, you just explain that you have got a postural hypotension, explain what is postural hypotension, and then say that there are two possibilities. Either you are having a side effect of risperidone or a higher than normal dose has been taken. Now, the side effect is quite commonly seen within the first week of treatment, even at a normal dose. Sometimes if you say that it's a drug-induced problem, patient can ask you that, so is my doctor did a mistake? Now, that is a very commonly asked problem. And you might get a little bit of surprised by this question, right? Like how I'm going to answer it. So answer it properly. Say that, John, I understand your concern and I appreciate that you are asking it. I'm sure that your doctor has prescribed what is best for you. What I would like to do before making a comment on that, I would like to look at the prescription first and find out that what is the dose of the medication that you are taking. And also, if possible, I would like to talk with your wife who takes care of your medication. So these elderly patients, sometimes they don't take care of their medication. Their partner do that. So sometimes their partner might just give them a higher dose of medication, okay, without knowing. So that's why before making any comment, just say that you want to look at the prescription to confirm the dose and also talk with the person who is taking care of the medication. In that way, you are answering the question, but you are avoiding the question. Do you understand what I'm saying? That is actually an Australian way of dealing things. Like they would never ever answer your questions directly, but somehow you will feel confused, like, oh, this happened. Okay, so this is how you should do it also. If you are not ready to answer a particular question, you make sure you do something like this. That means you first find out what actually happened before commenting on it. When you comment on it, it makes it like it is done. You can't undo it. If you say, yes, it can be your doctor mistake, that doctor is in a hot pursuit. So you don't do that unless you are sure about it. Okay. And obviously, we will do some investigation in this case. If it is a risperidone-induced postural hypotension, and if this patient in the emergency department, you can keep the patient in the ED to observe the patient, do some blood test, including a risperidone blood level, to find out if the patient getting a higher dose of it. You can call the psychiatric team to review the medication as well. They might adjust the dose of your current medication, or they might decide to switch it to another one. Okay, so it doesn't come in the exam too much, but now you at least know how to manage it. If management of postural hypotension comes, then along with the specific management, there are some regular advice that we do. So say that also, please make sure that you take your medication exactly as prescribed. Have a routine to take it at the same time every day. If you forget to take a dose, take it within the next few hours. Otherwise, skip the dose. Please do not double the dose. You need to continue taking the medications even if you feel well. Never stop the drug abruptly. Inform your doctor if you develop any side effect. And then there is a half-minute rule that you can follow. When you get up in the morning, sit up slowly and stay there for 30 seconds. Put the legs over the side of the bed for 30 seconds and slowly get up and walk to prevent any dizziness. So that's how we call 30-second rule. Patient sit up, stay there for 30 seconds, and then hang their leg at the edge of the bed. Stay there for 30 seconds, and then they gradually stand, and then wait for a few seconds, and then walk. In that way, the patient body will get adjusted with this sudden change in posture. All right, so that was all about the postural hypotension. Any question, guys? Next is vasovagal syncope. Now, this is a very important case, and this case comes with a lot of different combinations. I'll talk to you about it. So, an 18-year-old girl fainted during marathon running fainted during marathon running during annual sports. Now fully recovered, mother came to consult you. History, PFE, tell the possible causes. So 18-year-old girl fainted during marathon running. Okay. Now marathon running, it is a very strenuous sport. What you will find out in your history that patient fainted during running and it was a very hot sunny day. Not only that, when you ask that did your daughter skip meal today, you will find yes. So she skipped breakfast and went for running marathon. So that's one other thing. So patient might have got hypoglycemic attack as well. And in your office test, if you ask about the BSL, you might get 3.6, 3.5, less than 4 millimole per liter, that is hypoglycemia. So that can confirm that the patient has got a hypoglycemic attack. What else you should ask in this case, apart from the typical history that we ask? 18-year-old girl. Yes, Dr. Sandesh, very good. So ask about it. That we need to make sure that I'm going to ask some of the personal questions, but please be aware that this will be confidential. So ask about when was your last menstrual period? Okay. If they say that it was 3 weeks ago, do you normally get your period regularly? Yes, doctor. Any problem with your period, like excessive pain or excessive bleeding? Why we are asking excessive bleeding? Yeah, if it is a menorrhagia, that can give you iron deficiency anemia, that can give this fainting episode. So that's why we need to ask about menorrhagia as well. So ask about this period in detail. So when was your last menstrual period? Is it regular or irregular? Any problem with your period, like excessive pain or excessive bleeding? After that, are you sexually active? If yes, do you have a stable partner? So if patient is sexually active, then you should always think about possible ectopic pregnancy, even just a normal pregnancy. Then in your office test, you have to order a urine pregnancy test. Okay, so those are the tricky point in here. There was a case where there were 4 causes of syncopal attack. This was this case. So one cause, obviously patient had a vasovagal syncope, VVS. So vasovagal syncope because it was a hot sunny weather and patient was running. That's one cause. Second cause, patient skipped breakfast and got a hypoglycemia. Third cause, in the physical examination, there was pallor. And if you ask properly, you will find out patient has got menorrhagia. So iron deficiency anemia, most likely one of the other reasons. And there was other one, I can't remember. So most likely there was another one, but this is how it comes. So sometimes it's not just one particular cause you will always get in the exam. You might get multiple causes leading to this similar problem. Okay, so find it out. That's the thing, that you just finish your history. If you find out one particular thing, that there might be something else. One other thing, that when you get hypoglycemia like this, like let's say in your office test, you found out that patient having a BSL 3.6 at the moment, what will you do immediately? Yes, offer that patient something which contains sugar, anything, either it's a jelly bean, either it's a glucose tablet, honey, sugar, anything, you should offer it. Okay, so you immediately say to the examiner that, examiner, because my patient's blood sugar is still low, I would like to offer her some jelly beans, or I would like to offer her a glucose drink. If you do that, you pass that case. If you don't do that, there is a high chance you will fail the case. Because this is very critical, because this patient is actually hypoglycemic, and you know that, but you're not doing anything. So it's very important. So some are very tricky in exam, and something you can miss, they don't bother, but some of the things, if you miss, it feels like you are not a safe doctor. This is one of them. Okay, so that's important to remember. Like during the exam pressure, these things come out of our mind. But in a normal situation, we would obviously do that. But just for the exam pressure, we tend to forget this thing. But be very cautious that if you see something which is urgent, even if there is no management, just say that you would like to do that. Okay, like if it is very urgent. Yes, if it is an unconscious patient, then IV glucose. So how will you explain vasovagal syncope? So say that now we are explaining it to the mother. What is the other important thing? Before you start your history, ask for consent, that do you have consent to talk about your daughter? Because the daughter is now 18 years. If we are talking to the mother, make sure that mother has the consent. So the temporary loss of consciousness that your daughter had today, it is what we call as syncope. There are many reasons behind it, but in your daughter case, there are two possibilities I am thinking right now. It depends how many causes you find. One is called vasovagal syncope. In this condition, in response to certain triggers, such as overexerting in a hot sunny weather, can stimulate a nerve in her body, and that can cause pooling of blood in her legs. And if there is lot of blood accumulating in her legs, then her brain will not get enough blood supply, and that's the reason she might have a temporary loss of consciousness. So what usually happens in vasovagal syncope, when you are overexerting, when you are standing for a long time, your vagal nerve gets stimulated, and vagal nerve causes peripheral vasodilation. Because of peripheral vasodilation, there will be pooling of blood in the lower extremities. So all blood is coming into your lower leg. So not enough blood going to your heart. If heart is not getting enough blood, obviously your brain is not getting enough blood. And that's why you are getting these fainting episodes. Please don't worry, it is a very common cause of fainting, and there is nothing you need to worry about. Also, there is another thing which can precipitate this attack is hypoglycemia or low blood sugar. As your daughter skipped the breakfast before running, most likely that has led to a low blood sugar. Also, we have measured it, which we have found as low. Don't worry, we will give her some glucose drink and she will feel fine. Okay, now if you get some other finding like I have also found during my examination that your daughter looks very pale. And during the history, you told that your daughter have heavy bleeding during period. So I'm thinking that that might also precipitate it. So it might be that your daughter is lacking hemoglobin in her body. Sometimes even it could be an iron deficiency because of prolonged heavy bleeding. So I would like to order a few investigation to find that out, especially doing a full blood examination, liver function, kidney function, and most importantly, iron status. Okay, so that's how you deal with these cases, and then give other differential diagnosis of syncope. Any question? There is a question of funny turn in exam. Funny turn is also a syncope cluster case. And funny turn, you ask everything that you are asking in the syncope cluster. Just one thing to remember, that sometimes it might be a case like this, like a young female patient, like a 19 or 20-year-old coming to you with a loss of consciousness. And that happened today in the morning. So you will find out that what actually happened, that she just got up in the morning and then opened the kitchen refrigerator, and just suddenly she lost her consciousness. There was no witness. So you will not find enough information about the syncopal attack. If you ask all the differential diagnosis and lastly come with the SADMA, you will find out that she had a binge drinking last night, because I think her friend had a birthday party and she had like 15-20 drinks of alcohol last night. And she can't remember anything after that, what happened. What actually happened in the morning, that she had a hangover effect from the alcohol, causing that loss of consciousness. Apart from that, it could be dehydration caused by heavy alcohol drinking. And also sometimes it's not just dehydration, sometimes it can be due to electrolyte imbalance caused by binge drinking. So those will be your differential diagnosis at that time. Okay, so that's one of the other case that you should think about. The last case about syncope cluster is the recurrent fall. And this is the last one we will finish with. So you guys can see now that how much cases we have done using the same format. And you don't even need to remember history and physical exam. That's the beauty of it. So recurrent fall is a very important case. It comes in the exam almost every few months. And every time the scenario changes. So that's why you have to be always open that it can be anything that can cause a recurrent fall. But recurrent fall is a condition of elderly population. So you have to just think that how the elderly lives in Australia. That perspective will give you more definitive finding. So recurrent fall can be due to anything that causes syncope. Other than that, you can just give some other differential, like polypharmacy can be a cause of recurrent fall, because elderlies in here, they take like a 15-10 medications. Postural hypotension is a cause which can be due to medication, bleeding, diarrhea, vomiting, fever. Vasovagal syncope, CNS CVS like before. Endocrine is one of the cause, like diabetes complication, either hypoglycemia or hyperglycemia. Sometimes even diabetic complication like diabetic retinopathy, diabetic neuropathy can cause it. Because retinopathy, obviously there will be lack of vision and patient might have fall because of visual problem. Neuropathy, patient might not even feel where they are stepping. And if they step on something slippery, they will even not understand it because they can't feel. They have this loss of sensation on their feet. So that can be a cause of fall. So peripheral neuropathy, diabetic retinopathy, hypoglycemia, all are very important causes of recurrent fall in elderly. Then electrolyte abnormality can be a cause, especially due to vomiting, diarrhea. Anemia can be a cause. And these three, this is mainly every elderly patient can have it. So problem with vision and hearing, home situation is very important to find out, especially do they live alone? If they have any support. If they live alone, then how they are doing all their daily activities. We need to find out that if there is a loose carpet in the home. We need to find out that if there is enough railing on their stairs. We need to find out if there is a poor lighting in their home. So loose carpet, poor lighting, lack of railing on the stairs, all of these home situations can lead to recurrent fall in the elderly. Okay, so always make sure you go in detail about it. And joint problem is almost every elderly will have osteoarthritis. So joint problem, that can be also important to find out. Okay, so along with your all other differential diagnosis, we are just adding a little bit of home situation, joint problem. We are adding the endocrine, anemia, electrolyte abnormality. So in the history, same like before, you start asking about the fall questions. So make sure you just divide it like a pre-syncope, syncope, and post-syncope. So in here, what happened before fall, during fall, and after fall. But important to find out the episodes, that how many episodes you had so far, what were you doing at this time? That means what exactly you are doing during these episodes of fall. These things will give you an idea that what is exactly going on, why this patient is getting fall recurrently. Okay, so ask the detailed episode, that if this is a 3 episode, ask in detail all the 3 episodes. So, and then obviously you will follow the same approach. Ask the differential diagnosis, so CVS, CNS, postural hypotension, anemia. These are same like before. When you come to the past medical history, you have to ask in detail. So how about your general health? Any history of diabetes, stroke, high blood pressure, or heart condition? Now patient says, yes, doctor, I have diabetes. So then you go in detail of diabetes. So how long you are having diabetes? Is it a type 1 or type 2? Is it well controlled? Are you regular with your specialist? Do you take any medication? If yes, then what medications do you take? Any problem with your vision? Any numbness, tingling sensation in your legs? All right, so you need to find out everything about the diabetes, because there is one of the case which is important for exam, and also because diabetic patient can get a lot of complication and that can lead to recurrent fall. We have to be detailed in here. So ask about that, like how long you are diabetic, is it well controlled, are you regular with your specialist, when was the last time you checked your blood sugar, what was it, do you take any medication, what are those medications, do you take it regularly? Okay, so all these questions will come. After that, ask about any other medication, because polypharmacy is one of the other cause. In exam, if you get a patient who gets recurrent fall, but there is no diabetes in the history, your next thinking should be that, is this a medication induced recurrent fall? Okay, because that's another important case. So you might find out patient taking multiple medications. One of the medications recently has been added, like a diuretic or antihypertensive. Ask about their home situation. Who do you live with? Do you have enough support? Any loose carpet? Any problem with lighting? Do you have any joint problem? Any problem with walking or keeping balance? Ask about SADMA. Ask about social support. So that's your recurrent fall history that you should ask. In the physical examination, same thing, general appearance, vitals, and BMI, because one of the important things that if you get a diabetic patient, you have to examine their eye, because they might have a diabetic retinopathy. So say that I would like to examine the eye. I would like to check visual acuity, visual field, and fundoscopy, please. When you say fundoscopy, examiner can give you a picture of diabetic retinopathy. Or examiner can say patient has got features of diabetic retinopathy. So that's one of the important findings. You will do the CVS examination like before, then do the CNS examination. In recurrent fall, you have to say that, doctor, I would like to do the full central nervous system examination, including the upper limb, lower limb, tone, power, reflex, sensation, coordination. So we call it ITPRCS. We do the inspection, tone, power, reflex, coordination, and sensation. So that's our neurological examination. Why we are being very detailed? Because this patient might have a peripheral neuropathy. When you say sensation, examiner will give you the finding that this patient has got Glock and Stokes loss of sensation into the lower leg up to the mid calf or up to the knee. So then you get another finding that this patient has got peripheral neuropathy. If there is a joint pain history, then say that I would like to do full musculoskeletal system examination, looking for any joint swelling and tenderness and any restricted movement. And lastly, do the office test of blood sugar level, urine dipstick. Okay. So in diabetic retinopathy and neuropathy case, you can get a patient who has BSL of, let's say, 15, which will be uncontrolled diabetes. In the urine dipstick, what you should ask for if you get a BSL like this? Ketone, right? Very good, Dr. Priyanka. So we have to ask for ketone at that time, just to make sure it's not a diabetic ketoacidosis going on in our patient. Very unlikely in the exam, but you have to make sure you ask it. Okay. So that's your physical examination for this particular case. What could be the positive point? So we already know that patient had 3 episodes of fall, diabetic for 10 years, tingling numbness in the feet, vision problem. Patient also have got knee joint pain, stroke, taking physio now. So there will be some problem with the balance because of the stroke. Physical examination shows fundoscopy, retinopathy features of diabetic, peripheral neuropathy, and BSL 16. So explain that most likely the cause of your recurrent fall is uncontrolled blood sugar causing few complications. One of the complications is peripheral neuropathy. In this condition, the nerve that supply your extremities got affected, causing numbness and tingling. And that's why sometimes you may not even feel where you have been stepping. And that can lead to having recurrent fall. Also, we have found some eye changes related to diabetes, which is affecting your vision. And that can also lead to further episodes of recurrent fall. Other than that, you are also having knee joint changes. That's why you might have some problem with your walking or keeping balance. That can also lead to recurrent fall as well. Please don't worry, now that you are here, we will try our best to make sure you have a good quality of life and making sure that you don't have fall anymore. It could be due to other causes as well, then give all other differential diagnosis. Okay, so that's how we manage the recurrent fall. Now, again, if management comes in the exam, it depends on the cause of recurrent fall. If medication is the cause, you have to review the medication, either reduce the dose or change the medication. You have to refer the patient to the recurrent fall clinic. Recurrent fall clinic comprises of a group of allied health team, which means that comprises of social worker, occupational therapist, then physiotherapist, then some community healthcare nurse. Okay, those are the people who will help this patient to prevent further fall. How they do that? Occupational therapist will come at home and they will assess the home situation. If there is any loose carpet, they will fix it. If there is poor lighting, they will increase the lighting. Anything at home, occupational therapist will deal with that. If patient needs any help with the household activities, social worker can help with that. And then physiotherapist, if patient having pain in the joint, physiotherapist can help the patient with some exercises. And community healthcare nurse will come and visit the patient. If the patient needs anything, they can coordinate it with their local GP or the hospital. Okay, so that's the recurrent fall clinic job. So that's the management of recurrent fall. Depending on what cause you find, you have to treat it accordingly. Any question, guys? That's the end of our today's session. A lot of things, right? But I hope that you guys enjoyed the session. You guys understood the importance of cluster-wise learning. And Dr. Priyanka, cerebellar or vestibular cause? Cerebellar cause, you can keep it in your head, especially if the patient having any dizziness. Normally, we only ask about, in the physical examination, you can ask about you want to do a cerebellar examination. That's fine. And Dr. Amit, do we get the pre-reading notes before sessions? Yes. The theory notes will be uploaded in your software once you enroll the course. And yes, if you want to read those things before the class, that's fine. You might not have got any of those notes in the software right now because we are waiting for the free 2-week session to over, and then everything will be uploaded. The last date to enroll the course would be during this first 2-week session. Okay, so please, if you are interested, then you have to make sure you enroll within this 2 weeks free session. But we will keep the admission open for this July. So even after 2-week session, if you want to, then until the end of July, we have this course admission open. The course, Dr. Anika, the notes are available until you pass. The videos of this recording will be accessible up to 10 months of your course. Okay, so within 10 months, most of the doctors usually appear for the exam. So you will not need any more video recordings after 10 months. If you need, then again, if you want to extend, there is always a way to extend it. But most of the time, you will not need it. And what is the allotted time for history taking physical examination management in case of recurrent fall? Now, they would not give you any specific time for it. You have to manage it by yourself. Usually, you would not get management in a recurrent fall case because it is very hard to finish in that way. So most of the time, history, physical examination, diagnosis with reason will be your task. So in that case, you will take 4-minute history, 2-minute physical examination, and 2-minute diagnosis with reason. That is your best allotted time in your head. BPPV, if patient comes to you with a recent onset of dizziness or vertigo, especially BPPV is a vertigo thing. So if vertigo is a feature, then BPPV will be your DD. All right, the last date of finishing this course. Can't remember actually. So the 5 months, let me see, I think we have given that. So it will be because we have started on 30th of June. So think about end of November. okay, or early December. And always, like, as I said, that if you guys are planning to appear exam in, let's say in October, November, then there is always a way, because we have been taking the course for a long time, right? We have a lot of previous videos which you can always go through if you are planning for appearing the exam like this year. Especially if you have got a exam date, you are more than welcome to go through our previous batch recording. Already we have given access to people who has got the placement. Okay, so that's not a problem. You can always use our materials and finish your course within your own time. But if you are not planning for exam this year, just to go with our flow. That becomes more convenient, and you will actually learn things in that way rather than just going through the recorded videos. No clock in exam. And Dr. Anika, if you are a beginner, honestly, I would always say, obviously, most of you are working. For working people, I would say that you should keep at least 6 to 8 months for appearing the exam, even more than that, because studying during working is very hard. So you're thinking about 10 months at least. Okay, because it seems that it is easy, but when you go into the depth of clinical exam preparation, it takes time. If someone's saying that you can finish the exam preparation in 2 months or 3 months, that's a very, very misguiding. And no one actually should say something like that, especially for a working people. You can't do that. Okay, there is a lot to learn, not to memorize, lot to practice. You have to practice physical exam. You have to practice all these classes that you are doing. You have to do a lot of role play. It doesn't come that easily. So you have to take your time. So for beginners, if you are working 10 months, or I would say if you are good, then 8 to 10. That's my honest one. If I would be a little bit of dishonest, I would say 6 to 8 months for someone who is really, really good, like who can deal with the work stress and family stress. For them, 6 to 8. But for someone who is not working, staying at home, yes, for you, you can actually appear the exam in 6 months. Okay, so that's how I would say in terms of preparation time. And that's actually an honest one. I could say 2 months, 3 months, but that doesn't make sense. No one can do that. It takes 2 months even to understand what is clinical exam, because that is a lot of things. It's not about like scaring you guys, because I have seen candidates. I have seen people trying to finish the exam in 2 months. It never ever ended up well. It can't be. Because this is actually something, let's say that it's like your specialization exam in your country. You have to know everything, every subject, every topic in detail. It's not just medicine, it's all. And there's a huge number of pages that you have to prepare. So make sure you have your time in your head. And there is nothing you need to hurry about it. You can learn, you can take your time and appear the exam. Yes, Dr. Priyanka, if anyone's access in the software is still pending, please make sure that you send a message again about it, or usually within the 2 weeks free sessions, everyone account will be approved. Now, Dr. Rashid, AMC exams, sometimes I have seen it happened in December. But it totally depends on AMC. They haven't opened the date yet for November, December, in my knowledge. So it depends that if they want to do it. Most of the time, November, I have seen a lot, but December, not always. Okay, so I can't say that it will happen this year. Class schedule are like this, yes, Saturday, Wednesday, and Thursday, 7:30 to 10 p.m. Yes, then usually November, then go to the February. That's how it happens. December, January, usually this is a Christmas time in here. So most of the time exam doesn't happen. No worries, Dr. Kylie. Yes, Dr. Anika, having a toddler is a job. I would say, like, if you are not working, but still you are doing a job, like you're doing a work. Like raising a toddler is one of the hardest work. Okay. So you have to take your time. Yes, Dr. Amit, the course material is enough. You don't need Karen notes, Marwan notes, nothing. You can't wear a watch in your exam. I know you were worried about the time. I don't know what's your name. Your name is showing as Australia, but yes, unfortunately, there is no watch. Yeah, see, Dr. Najia, so you are doing double job. I know that most of you are doing it. You have a small kid and you are doing job. That's why it is very hard, right? So don't worry. It's not a race. You are doing your own job and you are preparing yourself and you are doing your best. Just think in your head that it is not a race that I have to pass clinical just like others within 5 months. If I am taking 10 months, there is a reason behind it. I might not be that confident. I might need more time to get my accent, to get my approach right. I might not have my initial university in an English medium school or college. I might need a little bit more time to talk about these things. And this is normal scenario. There is no shame in it because you are doing your best and you are trying. That's all that matters. Okay, so take your time, learn what you really need to do, and then appear the exam. All right, so hopefully everyone will have a good journey with us, and make sure you join this free 2-week session. Even though you don't need to join the course, do these 2-week sessions because this is how you will learn how to prepare. So make sure you do that. And obviously, if you need help, we are always here. And if you want to admit into the course, inbox or you send us email so that we can start the process. All right. So hopefully everything will go on well, and you will have your dream journey, and you will pass this clinical exam as soon as possible. Don't forget, we have a class tomorrow, and tomorrow class will be taken by Dr. Cynthia, who usually take your role play sessions in the course. So hopefully you will enjoy her session. Yes, you can pay in 2 installations, Dr. Amit.